Hi, I'm Brooke Alderman. I am a marriage and family therapy intern. I specialize in eating disorders and other process addictions. I started off my traineeship and my clinical experience at Partnerships to Uplift Communities, which works with 13 bilingual charter schools in which I started to see addiction starting in high school, then transferred to now I'm a primary therapist at a New Journey Eating Disorder Centers in Santa Monica, and I have a private practice in Beverly Hills, both specializing in eating disorders.
Okay, and can you talk a little bit about the different forms of eating disorders or the different sides of the spectrum?
Per the DSM, which is the Diagnostic Statistic Manual, there are 3 classifications, and then there's sort of some specifics under each classification. So there's anorexia nervosa, there's bulimia nervosa, and then there is eating disorder NOS. And recently, in the newest DSM, they've now added binge or compulsive eating. Obviously, anorexia, I think, is more of the well-known, maybe actually not as taboo of an eating disorder. You can generally see it on someone, as opposed to bulimia or binge eating or compulsive eating tends to be something that you would maybe say to somebody, well, I had no idea, you look very normal. Under bulimia, there are things that range from over-exercising, which is purging through exercising, and then there's the typical binge purge, which is the overconsumption of food, either really quickly or even some people do it over a long period of time and then purge what they've eaten. Same thing goes for the over-exercising. They will eat a certain amount and then purge their calories through exercising. Through anorexia, there's also, there's many different subsets. One of them is orthorexia. We tend to see that a lot, which is the eating of very clean foods, raw, vegan, vegetarian, a lot of fear around foods that have additives and preservatives. And then there's the compulsory binge eating, which is generally, when you hear of like maybe food addiction, is like sort of eating your feelings per se and not purging them out. And those are really sort of, we see things though ranging from diabulimia, which is using your insulin to mess with your hunger fullness cues and basically eating yourself until you have spiked your insulin levels so high that you purge your food.
Okay, and a little more about the diabulimia. You did mention the insulin, those that are insulin dependent.
Mm-hmm.
Can that obviously affects the other parts of their body in other ways? Is that, I know with substance abuse, people get a high off of that are even not even just with diabulimia, but is there a feeling of like getting high after someone purges, mm-hmm. or like to see how long they can go after like in between meals?
Yeah, definitely. There is an element. They're seeing a lot of brain study stuff about starvation, but also binging, purging, and how those sometimes actually hit the same dopamine receptors as using drugs, like heroin or ecstasy. Yeah, you will see people get a high off of this feeling of starvation and the emptiness, and clients tend to say that that you hit past a feeling of hunger and it becomes sort of this empty numbness that is very hard for clients to break that pattern of. And definitely with the bulimia, there's a ritual nature of binging and purging, which a lot of people say they actually black out, which is a feeling they like because they're numbing. And with the purging, there's definitely a release and a sense of a high. Mm-hmm.
And I know that for those that are suffering with substance abuse and chemical dependency, there is like a big part of them not wanting to give up their addiction, or the part that they love the most is the actual ritual and not necessarily getting high. So mm-hmm. What I'm hearing from you is that there's a correlation between, or not necessarily a correlation, but on both with chemical dependency and substance abuse and eating disorders, that there are rituals and frankly there are rituals stemming back and forth.
Mm-hmm. Yeah, there are a lot of similarities, and this is why some treatment facilities, some therapists really focus heavily on 12 steps because they say that it is about the ritual that you need to break. And therapists use a lot of cognitive behavioral therapy, dialectical behavioral therapy to really start breaking patterns. And that's why sort of those first 30-ish days of sobriety and clean time from your behaviors is so pivotal.
Okay. And in your findings with the populations that you work with, is an eating disorder generally the only thing that your client will struggle with? Or is there generally a co-occurring disorder that comes along with it?
I have never seen somebody come in with just an eating disorder. The most common sort of co-occurring or comorbid diagnoses that we see are anxiety and depression. That's kind of, I'd probably say probably 100% of the clients that come through this treatment center or that come through my private practice. Also see a lot of PTSD, a lot of bipolar, and a lot of substance dependence or abuse.
Okay. And is it, and I understand that you guys are a dual diagnosis facility, or even you, because you've been working with so many comorbid disorders, is it beneficial to treat them both at the same time, or do you like to work on one, like, or do you do one before the other?
Research has actually shown that when you kind of hit 2 in 1 and you work on both at the same time, that your results and your ability to maintain your sobriety or your clean time with whatever your process addiction is, even if it's an eating disorder, is higher. It's a higher chance than if you were to work on your eating disorder and then go to another facility for your drug addiction or your psych pieces, and that when you work on them together, there tends to be a higher percentage outcome of lasting sobriety.
Okay. So generally, the longer a client is in treatment, or the longer the client is in some sort of treatment setting, the better the outcome is, especially if they work on both of them at the same time.
Yeah, and obviously the goal is to reintegrate them back into their life. So the longer they're in treatment, given a proper step-down care and step-down of levels and days and hours in programming is ideal.
Okay. And in the clients that you treat, do they tend to trend toward a specific population? Like, do you see more women with eating disorders, more men, adolescents, even the LGBT community? Can you expound a little on that?
I think the majority of our clients, and if I could break it down to percentage, that would be hard, but my private practice is all women. My clients here and the clients in this treatment facility range. I think, we have a good amount of men. Currently we have 5 or 6, so it's not like there's no men, but I think women tend to come forward more easily and quickly than men, because with men in society, eating disorders are a bit taboo, and there is a very shameful piece to having eating disorders, but especially for men, because I think society believes that women are the more chosen population to have this disorder. There is a high incidence of eating disorders with both gay and straight men and gay and straight women, but there's a high percentage of gay men.
And why do you think that is?
I think that there's 2 parts. I think that there's a desire to, for certain gay men to attain a very, very slim physique, and many clients refer to themselves as twinks, and to maintain this sort of, with the body image piece of eating disorders, because there is so much, to maintain a twink-like body shape. And then there's the men that are on the opposite spectrum that overexercise. You tend to see the orthorexic bulimia through exercise component. And that's, I think, to probably attain some degree of masculinity when society already views gays as sort of effeminate.